Hello, everyone. It's a pleasure to be talking with you in this IOHSK conference. I would like to thank all the organizers and congratulate all the organizers for this excellent meeting. Unfortunately, I'm not present in person with you, but we have to talk virtually, but it's a pleasure to be participating in this conference. And I would like to give a special thanks to Professor Hosung for his invitation. And we will talk today about community-based exercise for promoting health in older individuals. And before we start talking about the benefits of community-based exercise, it's important to contextualize about the population aging. So today, the population aging is a worldwide reality, and it is expected to continue to increase during the next decades. For example, in 2050, it is expected that most of countries will have more than 15% of older individuals, and it will increase in all countries worldwide. The main increase is almost to double for today older population, and this increase to 2015 is almost 2 billion older individuals more than we have today. And specifically in Brazil, we have an increase for 43.3 million in 2031 and to 58.2 million in 2060. So what's the problem with this population aging? The main problem is that we have a loss of general physiological function, organic function during the aging process. And it would not be a problem if you have adequate behaviors and adequate we practice physical exercise, and if you don't have any specific event and disease that could increase this organic function loss during the aging process. So this is mainly 20% of organic function loss during the aging process, but because of our unhealthy behaviors, we have more than 7% decrease in almost all our organic process. So the higher percentage of fat mass, the use of drugs, not only formal drugs, but drugs that are not used adequately, the use of tobacco, the high prevalence of salt in our nutrition, in our dietary habits, and the absence of adequate nutrition, and the high prevalence of sedentary behavior and the low prevalence of physical inactivity will reduce a lot our organic function during the aging process. So it's important to have a healthy aging that we combat inadequate behaviors and that will do adequate behaviors, okay? Specifically regarding physical activity and exercise, if you do physical activity throughout our life, we will have positive impact in our physical capacity, risk factors, and the body composition. That is, we'll have a a lower reduction of cardiorespiratory fitness, muscle strength, power, and resistance. We will have a lower increase in risk factors, insulin sensitivity, lipid profile, obesity, osteopenia, and the other risk factors. And we will also have a low impact in our body composition, a lower reduction of muscle mass, bone mass, and a lower increase in fat mass. In contrast, if you don't practice adequate level of physical activity, you have a greater impact in our physical capacity. You have a greater loss of cardiorespiratory fitness, muscle strength, power, and resistance. We will have a greater risk for developing these risk factors. We will have a greater loss of muscle mass, bone mass, and a greater increase in fat mass. Thus, the impact in chronic disease will be less intense if you are physically active, but if we are not physically active, if you don't practice adequate levels, the risk of developing chronic disease and to develop incapacity at older life will be higher. And the risk of premature mortality will also related to this practice. If you practice adequate levels, it's well established in the literature that the risk of premature mortality is lower, in contrast to those that don't practice adequate level of physical activity. Specifically, in the mortality-related physical activity relationship, the physical activity-related mortality is about 5.8% for arterial coronary disease, is about 7.2% for type 2 diabetes, 10.1% for breast cancer, 10.4% for colon cancer, and in 2018, the all-cause mortality that could be attributed to physical activity was about 9.4%. In contrast, if the worldwide population have met the minimal quantity of physical activity indicated by the World Health Organization, that is 150 minutes per week of moderate intensity exercise, or 75 minutes of vigorous aerobic exercise, added with at least 2 weeks of resistance of strength training to working all our body muscles, the number of deaths that could be prevented in 2018, it's almost 3.9 million worldwide, and the global region that could more benefit of meeting the quantity of physical activity is Africa, but all global regions would benefit of meeting the minimal recommendation of physical activity. That for young and middle-aged adults, that's what I told, but it's important to note that we can get additional health benefits if you practice more than the minimal recommendation. And specifically for older individuals, not only aerobic and strengthening exercise are required, but it's important to add to their routine the practice of balance exercise to reduce the risk of falls. And as in young and middle-aged individuals, if you practice more than the minimal recommendations, we will have additional health benefits. And these benefits can be achieved even if we start practice physical exercise or physical activity later in life. It's not too early to practice, to start practicing physical exercise, physical activity, to reduce the impact of their benefits in our health. For example, in this review by Bulls, they summarize the effects of 3 cohort studies that assessed cardiorespiratory fitness as a risk of all-cause mortality. They measured the cardiorespiratory fitness in 2 different time points. The first time point, the baseline time point, was with the individuals with age between 55 and 70-year-olds. The second time point was 10 years later, and the third time point, when the risk of the mortality was measured, was 20 years after the first time point, the baseline time point. And they classified the individuals in 4 groups according to the change in cardiorespiratory fitness during the first 2 time points. The individuals that were cardiorespiratory fit at baseline and continued fit at the follow-up. The individuals that changed their cardiorespiratory fitness, we have a group that were fit at the baseline, but reduced their cardiorespiratory fitness during follow-up. We have the other group that were unfit and then started to practice physical activity and exercise and improved their cardiorespiratory fitness during the follow-up. And the fourth group, the last one, were the individuals that were unfit at baseline and continued unfit during the follow-up. So what was the risk of death? The greater risk, obviously, was with those groups that were unfit at baseline and continued unfit during the follow-up. The lowest risk of mortality were in the individuals that were fit during baseline and continued fit during the follow-up. But we have an interesting fact, that's why it's not too late to start practicing physical exercise or activity. The individuals that were unfit at baseline, but improved their cardiorespiratory fitness and were fit during the follow-up, have the same risk of cardiovascular death, relative risk of all-cause death, than those that lost their fitness during the follow-up. So they have similar and not statistically different risk of mortality, those that were fit and lost their cardiorespiratory fitness, but that started practicing physical exercise, reduced a lot, almost 50%, the risk of premature death. So it's never too late to start practicing physical exercise. If physical activity and exercise is too good to our health, reduce the risk of chronic disease, reduce the risk of premature deaths, so why too many people are still don't comply, don't have the adequate adherence to the recommendations of physical activity? Mainly the older individuals that when we have at the older ages, we don't have the same busy compromise with our work. We have some of them don't have to work anymore, so they have more time to practice physical activity, physical exercise, but it's not a reality. The adherence, the compliance to the recommendation is too low, even in older individuals. So the answer for this, it's not it's not known, it's not known, but trying to counteract this low adherence, community-based exercise can be an alternative than individually prescribed or individually oriented physical exercise. What the literature shows to us when comparing community-based exercise with individually based exercise, specifically regarding financial, human, and material resources, is lower for community-based exercise when compared to individual-based exercise. Because of these lower resources of material resources, one professor can deal with a lot of people at the same time. We don't need to any equipment. We can perform community-based exercise like these individuals just using our body as a resistance, as equipment. We don't have too much financial, and they are the facility of communication and interaction between these older individuals that the literature more shows us that the adherence is greater in this type of physical exercise than exercise routines when comparing to individually prescribed, individually oriented physical exercise. We also can reach large populations in community-based settings than in individually based exercise settings. And we also have some literature showing us that this type of training can improve physical fitness, can reduce cardiometabolic risk factors, and can reduce daily living physical, they can increase daily living physical activity, and can also reduce the risk of falls. So that's what the current literature showed to us before we started to study this type of exercise. Our experience regarding community-based exercise started with this project in Portuguese. Ativa a Melhor Idade is the name of this project. In English, it will be something like Active Best Age. Our experience with this project started in 2017. It started with a community program in our university, and when we used this community project also to perform our researches, our undergraduate thesis of our students, our Master of Science, and some of our PhD thesis of our students. This group of people we are working is associated with a non-governmental association that have the focus to promote the social communication between these older people, specifically with those that are under social vulnerability. This program works in 4 neighborhoods in our city, in neighborhoods that they are of people under social vulnerability. And we started to comparing the effects of different types of community-based exercise. So we try to assess in this four neighborhood the impact of different modalities and intensity of community-based exercise on physical function, on hemodynamic and vascular variables, and quality of life and mood profile. All women were were of low income. So before we started, we performed several physical functions, and also we give a brief discussion about the importance of performing physical activity and of doing physical exercise. Here we have some videos to illustrate to you how was the performance, the resistance exercise, the strengthening exercise. All the exercises are using the body weight. So we have squats, push-ups, arm curls, just using body weight. Or, for example, for some curls, we use the chairs, and using the body weight, the wall and the chairs to perform the exercise. And some of the groups also performed aerobic exercise. One group performed continued moderated aerobic exercise, and another group performed high-intensity interval exercise. All sessions were performed in group. Here we have a brief view on the high intensity is when they have to run during 1 minute and walk to recover during 2 minutes. And we compared at a short time these three groups. One group performed only resistance training, the whole body resistance training, but only using the body weight as resistance, and two groups combined aerobic and resistance exercise. One of those groups performing high-intensity interval training combined with resistance training, and the second group performing moderate intensity continuous training combined with resistance training. The total amount of exercise were similar between groups. 4 sets for this group, 2 sets for these groups, these two groups, about 25 minutes of high-intensity interval training and 30 minutes of moderate intensity continuous training. And these individuals at our first study was followed up for 16 weeks, and the functional, hemodynamic, and quality of life variables were assessed both at baseline and at follow-up. Here, the training program, the high intensity combined with resistance training, performed both aerobic. Here, the progression along with the weeks, 4 bouts of high intensity with active recovery, progressing for 5 bouts to 6 bouts, and finalizing the last 2 weeks with 7 bouts, 1 minute of high intensity exercise, interspersed with 2 minutes of walking. So 1 minute high intensity, 2 minutes active recovery, and the resistance training, 1 set in the first 5 weeks, and 2 sets in the 6 weeks to the 12 weeks. The same progression for the moderate intensity combined training with resistance training for aerobics, and 30 minutes at the end of follow-up, and 4 sets for the resistance training group. What we found with these three types of training. Only high intensity combined with resistance training improved waist circumference during the follow-up. Only improved, no, sorry, is improved. Improved 98, reduced to 94. Only high intensity interval training improved diastolic blood pressure, while the moderate intensity combined with resistance training improved the resting heart rate. Regarding body mass, waist circumference, and blood pressure, there weren't any improvement in the group that in the resistance training group. Specifically regarding the functional capacity, the best intervention was for sit and hit for flexibility, and for hand grip strength was high intensity combined with resistance training, while the best intervention for improving the 5 times sit-to study was the resistance training alone. However, the combined training, both high intensity or moderate intensity combined with resistance training, improved the 5 times sit-to study. And only the resistance training alone improved significantly the time and up and go test. We followed up these older women for more than 9 years, 9 months, sorry, 9 years, no, 9 months. And with our training started in March and ended in December. So 9 months of training, exercise training, and we interrupt the training and reassessed the women after 3 months of this interruption. In this long follow-up, we didn't assess it only the effect of these 3 training, but we also assessed the effect of the training interruption and again, physical capacity, body mass, waist circumference, but we added the arterial stiffness measured by carotid femoral pulse wave velocity, both at 9 months and after 3 months of follow-up. The training session was similar of that of the first 12 weeks of follow-up, and we found that both at 9 months follow-up, both combined intervention were effective for reducing the waist circumference, high intensity combined with resistance, and moderate intensity combined with resistance. Both improved, but we have a small return of this waist circumference after the training interruption in the moderate intensity combined resistance group, while the group, the high intensity combined resistance training, didn't return the waist circumference. They maintained the waist circumference reduced even after the training interruption. Regarding the pulse wave velocity, only the high intensity interval training combined with resistance training reduced the carotid femoral pulse wave velocity. Only this type of training were effective to reduce the arterial stiffness, and all interventions improved the flexibility, but only the combined intervention was effective to maintain this improvement after the training interruption. The resistance training alone, the older woman lost the effects of exercise after training interruption. The same behavior occurred in their hand grip strength. All interventions were effective, but only the combined interventions maintained the improvement, and while the here all the interventions lost the effectiveness of the training interruption. All interventions were effective to improve during training, but the training interruption, the training cessation reduced the muscle strength, and then so any intervention were effective to maintain hand grip strength. Regarding the 5 times sit-to study, sitting to stand, only the combined intervention maintained the improvements after the training cessation, while the resistance training improved during the resistance, but there was a tendency toward a loss of the improvement during the training cessation. And the time up and go, all interventions were effective, and this effective of the interventions were maintained after the training interruption. And finally, the walking capacity, there was an increase in the 6-minute walking distance, similar increase after all the interventions, but after the training cessation, the only group that they maintained at least part of the improvement was the combined high intensity and resistance training. The other groups, the walking distance after training cessation returned to similar levels than baseline. Here, moderate intensity combined with resistance, and here, resistance training alone. We also measure the effect of this type of intervention during the COVID-19 pandemic. I don't know why the other videos aren't showing that. Let me see if I can show. So we made intervention, virtual intervention using body weight, doing videos to share with these older women. Most of them have problem to access these videos, these classrooms. We also made the Google Meet classrooms during the COVID-19, and unfortunately, we still didn't assess the statistical assessment of the intervention during the COVID-19, but in the next months, we have the results about the interventions of community-based interventions during the COVID-19 pandemic. So in summary, what our experience showed to us that during the 9 months of the community-based interventions, any intervention were effective to improve physical function, both flexibility, hand grip strength, sit to stand, time up and go, and walking capacity. However, only combined interventions, both high intensity or moderate intensity, were effective to reduce waist circumference, while only performing high intensity interval training associated with resistance training were effective to improve blood pressure and arterial stiffness. These results suggest us that combined aerobic and resistance training are the best intervention for improved health in this type of population, in older women under social vulnerability, low income, older women. However, if we have to have a greater benefit specifically in blood pressure and the arterial health, in our arterial health, the high intensity interval training is more effective than moderate intensity combined training combined with resistance training. Regarding the training interruption, the training cessation, all interventions were only partially effective to maintain the sit-to-stand performance. Only combined aerobic and resistance training were effective to, at least in part, maintain the walking capacity and the waist circumference improvements, and only high-intensity interval training combined with resistance training were effective to maintain, at least in part, flexibility, walking capacity, hand grip strength, and arterial stiffness improvements. So our experience shows us that performing group exercise using only our body weight as a resistance, but combining this type of strength training with high intensity interval training is both effective and safe for improving health of older individuals, older women under social vulnerability. Okay? So I would like to thanks to our whole group. Without these guys, this work would be possible. So I would like to thank all of them, and would like to take with you our contact if you have any question, if you have to talk about our experience, if you would like to conduct some research and collaboration, I'm open to talk. So this is my contact. So thanks, obrigado to everyone, and see you.